I'm Dr. Blevins with Pituitary World News, and we're here at the 2025 Endocrine Society Meeting in San Francisco, California, and I'm fortunate to have caught up with Dr. Ralph DeFronzo, who's probably the most eminent diabetologist that's ever lived on the planet. So, Ralph, welcome to our video today. So
I love the introduction.
Yeah, it's great to see you once again.
Yeah,
so
it's good to be here with you.
There's been a lot of interest of late about the incidence of unknown or hidden hypercortisolism in patients with diabetes. I wonder if you could share with us what some of the results of some of the studies have shown recently.
This is a really exciting area. So about 2 years ago, the Cortisol people, Dr. Einhorn, told me he was resigning his position at San Diego to join Corcept to study exactly what you just said. What is the incidence of hypercortisolism in people with poorly controlled type 2 diabetes? And he asked me if I had to project the number. I said, oh, maybe 5%. And I have to say, I joined up with the team, and I'm still in shock that it turned out that if we look at poorly controlled type 2 diabetic patients, about 25% of them turn out to have hypercortisolism. And I guess what really struck home, we were one of the sites that were part of the Catalyst trial, and of the first 33 people that we screened, 13 of them, that's 39% of the people, turned out to have hypercortisolism, and I was shocked.
That is remarkable. This condition is definitely far more common than we expected it would ever be seen in patients with diabetes. Now, when it comes to the uncontrolled diabetes, tell us what you mean by that.
Yeah, so the criteria that we used in the Catalyst study were people with a A1C above 7.5, and we screened them, and you had to be on you could be on 3 oral agents and be poorly controlled. You could be on insulin and a couple of oral agents. You could be on 2 oral agents and have either a micro or macrovascular complication. And because cortisol also raises your blood pressure, you could be on 2 oral agents and 2 blood pressure medicines, but you had to be poorly controlled. And the mean A1C in this Catalyst study turned out to be above 8.5. So these were really poorly controlled people, despite the fact they're taking the medicines and they're taking the big guns. There are a lot of people on tirzepatide or Ozempic, and there's really no reason why a person should not be responding to these drugs, which are phenomenal.
Yeah, so the patient's doing the work, the doctor's doing the work, the pharmaceuticals are doing the work, but they're not responding.
Yes.
And that's a clue, I suppose, that indicates that we need to consider a secondary cause of hypertension and diabetes like hypercortisolism.
Absolutely. You know, this is very similar to the hyperaldosterone story in hypertension. 15 years ago, when we started to evaluate people who had refractory hypertension, none of us thought that the incidence of aldosteronism in these people was going to be 15%, or in some places even higher. So this is kind of the parallel for poorly controlled hypertension, but poorly controlled glucose. Hyperaldo, hypercortisolism.
So I live in the pituitary world as a pituitary endocrinologist. Tell me what your colleagues in metabolism and diabetology think about this information. This is a revelation. And it implies that for decades, maybe even since the beginning of therapy for diabetes, we've been missing people with an underlying cause of hypercortisolism. How has this finding been viewed by the community of people who take care of diabetes patients?
In the diabetes field, this has actually caught on pretty quickly.
Interesting.
Yeah, I thought back as an endocrine fellow training at NIH and Hopkins, and then, practicing. I've only seen really 4 cases of the kind of people that you see with pituitary adenomas or ectopic ACTH who look like Harvey Cushing's, classic mini G.
Right.
Puffy face, stria, buffalo hump, proximal muscle wasting. That's not how these people present. And therefore, we haven't been looking for them. But now when we look for it, it's incredible that even mild elevations in the cortisol that you don't pick up by looking at urinary free cortisol, which is normal.
Yeah.
You really have to do the dexamethasone suppression test. And you see when these people don't suppress normally, all of the hypercortisolism, you understand insulin resistance in the muscle, insulin resistance in the liver, insulin resistance in the fat cell, impaired insulin secretion. Even these modest increases are really making it very, very difficult for diabetic patients to control their disease. And we actually have a drug. You know this well because mifepristone was really approved by you pituitary
Exactly,
folks.
for hypercortisolism, exactly. Well, I echo your observations that many patients with hypercortisolism, even marked hypercortisolism with a pituitary tumor, don't look like Harvey Cushing's patient, Minnie G, for which the disease was named after him because of the case reports. I've always felt like those people who do have that classic appearance probably have the underlying genetics of metabolic syndrome, but I don't have a way to test or prove that. But it leads me to the next question. You developed a remarkable scheme that I reviewed first a few years ago called the ominous octet, where you talk about the different things that sort of contribute to and lead to beta cell dysfunction, hyperglycemia, and all of that. How does this new information change that octet? Does it become a nanotet or whatever the term would be? Or
I'm glad you brought that up.
So
when I gave the Banting lecture in 2008 at the ADA, I called it From the Triumvirate, Three Problems, Muscle, Liver, Beta Cell, from the triumvirate to the ominous octet, a new paradigm for the treatment of type 2 diabetes. Now, over the years, everybody's tried to add 9, 10, 11. I've never been convinced. A good friend of mine, Dr. Jim Gavin, he's got it up to the egregious 11. I've always stayed at the ominous octet. But now, based on what we think is the incidence of hypercortisolism in the U.S., we're talking about 1.2 million difficult to control diabetics. I think now it's time to make hypercortisolism number 9. And so I've added it. I now actually have called it the noxious 9.
The noxious 9, I like that.
There's a very nice review article. It will be online, I think, this month. Where I've reviewed the pathophysiology of hypercortisolism as it relates to glucose intolerance. And you'll see the adrenal gland. You guys will be happy with this. Not the pituitary, it's the
excellent.
Adrenal.
Yeah, well, the pituitary is the master there.
Of course.
But at any rate, the other thing that I learned about you today is that we're fellow Hopkins alums.
Yes.
Maybe that's why we've gotten along so well all the time. And I wish you well in the rest of your career. And thank you for everything you've done to contribute knowledge to this field. And I look forward to learning more about your thoughts over time as this field evolves.
I appreciate the kind words and glad I could be here with you today.
And thank you for joining us here at Pituitary World News today at the Endocrine Society meeting.
Thanks again.
All right.
All right.